My name is Sachita Shah, and I'm an emergency physician. I work at University of Washington in Seattle. It's an urban academic teaching institution. So I work with resident physicians and medical students who are learning emergency medicine. I have been working in the trauma hospital. I work clinically at Harborview Medical Center in Seattle. And as you may know, Seattle was one of the kind of early, fortunately, epicenters of the American portion of the pandemic. We were treating COVID patients before we even knew that we were treating COVID patients. We started seeing patients coming in with multifocal pneumonia in both lungs who were really sick and really not oxygenating well, but they didn't really fit the criteria given to us of, well, they haven't traveled to Italy, so they couldn't have COVID. And it very quickly kind of realized that we were having local transmission just among people living in the community around Seattle. So even hour by hour, and certainly every few hours, our protocols were changing about who we were testing. Initially, we were just screening for fever and cough, but then a lot of the patients don't have fever. So we started screening for shortness of breath, and then we added COVID toes and inability to smell and all of these different symptoms, including just fatigue. And so pretty soon we were screening pretty much everybody. It was really difficult to figure out what was really happening during the time when we were seeing the initial wave of COVID patients in March. The majority of the information we were getting was through, honestly, speaking with and texting with physicians in Italy and Spain, and people putting up informal kind of descriptions of, here's what the labs look like for my last 10 COVID patients, and using that because there was no time for the science to catch up. We also have all curtained rooms, and the curtains don't reach the ceiling or the floor. And so it was a big push among our physician and nursing group to work with infection control and engineering to figure out ways to separate the patients, separate ourselves, put up plexiglass, put up plastic, but anything creative to really try to contain germs. I also do a lot of learning about diseases that we don't see here in America as much, less, tuberculosis, less malaria, other tropical diseases. With that background, especially being used to taking care of tuberculosis patients, I felt really comfortable in an N95 mask for hours, or working in the heat, or not being able to eat and drink because we have a mask on our faces. I was used to thinking about creative drug choices if we ran short of certain antibiotics, and certainly used to reusing equipment. They wash and hang out the gloves to dry. They don't throw them away after a single use. And most of the places I've worked, and those respirator masks are not single use in most of the world the way they are here. Our situation has changed dramatically. We did overall, I think, a really good job as a community in Seattle and even in Washington State to flatten our curve initially. And then I think people got tired of being at home. It got nicer weather. There are a lot of young people who believe that they won't get sick from coronavirus. True that your chance of dying as a 20-year-old is much less than if you were 80, because we don't yet have widespread vaccination and we don't have a treatment. It is really the only thing we can do to help save lives as a community is to wear a mask, do hand washing, stay home if you're sick. And if we can do them right, people's lives will be saved.